Thank you for coming to our upper extremity arterial duplex lecture. So we covered the upper extremity venous last week, so the anatomy should be pretty familiar, and so we should be able to move through this lecture relatively rapidly. Our objectives for today are to list the blood vessels imaged during an upper extremity ultrasound evaluation while identifying normal and abnormal spectral Doppler waveforms, describing the scanning techniques used to properly insonate upper extremity vessels, which can be challenging, and define diseases that impact upper extremity arteries. Some of the diseases that we're going to see in the upper extremity arterial system are going to be a lot less frequently affecting patients than those of the lower extremity system. So we should have hopefully a lot fewer of these or more negative of these exams than for our lower extremity arterial. Some of the causes of the diseases in the upper extremity are due to mechanical obstruction. One type of mechanical obstruction is known as thoracic outlet syndrome, which we're going to discuss multiple times throughout this lecture. Another cause of arterial issues in the upper extremity would be embolism, so a plaque that has dislodged or built up on in a vessel and clogged the pathway of blood to proceed through that vessel. Then we have trauma, which could be blunt force, but more commonly would be some sort of penetrating or iatrogenic trauma to the vessel, which could cause some disruption there. And then we're going to look a little bit at Raynaud's disease or Raynaud's syndrome, which can cause digital artery vasospasm, which can affect the blood flow in the upper extremity significantly. And then finally, we're going to be looking for digital artery occlusion because, of course, if an artery is occluded, then we're not being able to provide blood flow to perfuse the tissues adequately. One of the easiest ways to think about the anatomy of our upper extremity system is to start with the aorta, or the origin of the blood flow to this region. So when we start off the aorta, we can memorize our vessels coming off of the aorta with the ABCs. So our aorta, or our aortic arch, is our A. From there, our first branch is going to be our B, and that's going to be our right brachiocephalic right here. Our next branch is going to be our C, and this would be our left common carotid. And our last branch off the aortic arch here is going to be our S, and that would be our left subclavian. Now, obviously, we don't just have a carotid and a subclavian on our left side. So in order to fully understand the anatomy of the right, we have to go back to that brachiocephalic. That brachiocephalic is on the right is going to give rise to our right subclavian and our right common carotid. So our ABCs in review is A, aortic arch, B, brachiocephalic, that bifurcates into the subclavian and the carotid. Second would be our C. This would be our left common carotid. And last, we would have our S, which would be our left subclavian. Now, if we look a little bit at that brachiocephalic artery, which is our first branch off our heart here, or pardon me, off our aortic arch here, we're going to see it divide into that right carotid and that right subclavian. Our subclavian then is going to give rise to some smaller branches that are going to be important, like our vertebral branches that go to our brain and some other lesser known branches here. So occasionally our right subclavian comes directly off our aorta, so that might be an anomaly you come across at some point. Now, if this is the case, some patients may end up having a little bit of difficulty swallowing or laryngeal nerve palsy. So that is something to be aware of with that right subclavian. Our second branch was our left carotid, or left common carotid, which we already looked at. And then we're going to go to our left subclavian, which we already saw come off our right, off of our brachiocephalic. We got our right subclavian. When we go across our aortic arch, we see that left subclavian come right off the aortic arch in that third position. So when we look at the subclavians, once they have originated, they're really going to act the same on both sides. It's just their origin that is slightly different. So our subclavian, like I mentioned, is going to give rise to those vertebral bodies that are going to go up our intervertebral foramina through our necks and feed the basilar artery in the back of our brain. Other vessels that are going to come off of our subclavian are going to be the thyrocervical trunk as well as the costocervical trunk. But these are much smaller vessels and don't get the same type of attention that our vertebral does. All the subclavian arteries are going to exit through the thoracic outlet. Now, this is an important thing to recognize because this is a very crowded area of the body where sometimes thoracic outlet syndrome can occur, which would affect the blood flow to the arm. So because they're going through that thoracic outlet, compression may occur of the subclavian artery, and we know when we have compression of any type of artery that can result in stasis of the blood flow, which can result in thrombus. It can also cause compression of not only the vessel but nerves in the area when our arms are abducted, and then that frequent assault to that vessel can result in weakening of the arterial wall and aneurysm development. Some of the areas we most likely will see compression in our thoracic outlet is where our subclavian crosses over the first rib between the anterior and middle scalene muscles. And this is called the scalene triangle. So here you see our scalene muscles coming down. Here you see the subclavian, and especially in people that have very prominent scalene muscles, you can see how that would compress the subclavian artery as well as the brachial plexus nerves in that region. Another place that it may be compressed is here at our costoclavicular space. So you see this is our clavicle coming over our first rib. And because the vessels are traveling between those two regions, that compression of the vessel between those two bones can cause obstruction of our vessel there. And then finally, and least frequently, would be our pectoralis minor muscle. So especially again, if that pectoralis minor muscle is hypertrophic, or maybe it's in a young person that's working out a lot, that enlargement of that muscle may cause compression of the artery. So something to be aware of in this region of anatomy. All right, now our subclavian then, as you see, it's going to come along through the medial axillary region. Once it gets past that first rib, technically we change the name of the vessel to our axillary artery. So as it crosses that first rib, the subclavian artery turns into the axillary artery and then progresses through the axillary region until it becomes the brachial artery. Now, it becomes the brachial artery at that level of the inferior lateral border of the teres minor muscle, or at the distal axillary region of the arm. At this point, it's going to, as the brachial, it's going to progress down the anterior aspect of the upper extremity or upper arm until it gets into the antecubital region here near the elbow. Now, at that antecubital region, this is where we're going to have those deep radial and ulnar branches originate. So our brachial is going to bifurcate into radial artery, which is going to follow down the lateral aspect or the thumb side of our forearm, and then we're going to have the ulnar artery that's going to travel down the pinky or medial aspect of our anterior forearm. Now, as they get towards the distal region of our arm, they are going to communicate with one another through that deep palmar arch. Now, because these are all deep vessels, they are relatively adept at creating collaterals when necessary from different types of obstruction. As I mentioned at the elbow, that's when our brachial artery is going to bifurcate into our radial and our ulnar. The radial will branch into those deep palmar arches. The ulnar is going to give rise to interosseous artery, which is going to feed the blood, which is going to feed the bone itself. And then it's going to course towards the wrist on the ulnar side, as I mentioned, or on the pinky side. And then it's going to terminate with that radial artery in that deep palmar arch, in the superficial palmar arch. The branches from the palmar arches give rise to the metacarpal and the digital arteries. So here we see the metacarpal are going to feed the proximal portions of our hand, whereas the digital arteries are going to feed the fingers. Now, some important notes about anatomic variance is that we do see Traditionally, we are going to see more anatomic variants of the upper extremity arteries than we do of the lower extremity arteries. So make sure that you're feeling a little bit flexible with where you're expecting to see these arteries at some time. Sometimes. One of the anatomic variants that we might see is the higher takeoff of the radial artery, where the radial artery bifurcates off of that brachial artery in a more superior region. We can also see accessory or duplicated brachial arteries, so it'd be two arteries instead of one. We're used to seeing two veins with these deep systems, but it's not that common to see two arteries. So that would be an anatomic variant of the upper extremity. And then our origin of the ulnar artery can also be in the upper arm, kind of like we mentioned with the radial artery. However, this is much less common than it would be for our radial artery. Now, when we are preparing our patients for this, we know that exposure to cold is going to cause vasoconstriction, which would affect our blood flow in our upper extremity. So we need to make sure that we're keeping our patient warm and we're keeping our examination room warm. We want to also be sure to explain the procedure to our patient, as is good protocol, and then obtain your patient history. So some of the patient history you would want to get is, why are they here for this exam? Are they having any pain? Are they having any claudication type experiences? Do they notice paleness in one hand versus the other? Things like that are going to be very useful in your patient assessment, as well as their history of any coronary disease or any plaques that have been identified in different parts of their body. Because if they're building up plaques in different parts of their body, they're going to be more likely to have some sort of atherosclerosis in their arms as well. Another thing that you can do is compare the diameter of both arms at the superior upper arm, lower upper arm, and then forearm and wrist regions to see if there's any significant changes there. This is going to be less integral for the assessment of the arterial system than it would be for the venous, but it can sometimes demonstrate where you're getting a perfusion, how good your perfusion is. You can also evaluate and compare bilateral pulses. So taking an axillary pulse, a brachial pulse, a radial and an ulnar pulse, and then comparing it to the contralateral side strength can indicate where you might come in contact with an issue. Obviously, if you're having a weakening of a pulse in a certain artery compared to the contralateral side, that would kind of allow you to hone in on that particular artery as a site of concern. And then finally, you're going to want to have your patient remove any clothing or jewelry that might be that might interfere with your examination. Your patient positioning for this, you're really going to typically use two different positions. We can refer to this one as the pledge position or a stop sign position. And that's where we're going to get the best access for our axillary arteries. Then as we proceed down the arm, usually these are pretty superficial medial arteries, so just having the patient lay with their hands supinated will usually give you the access that you need. Now, when you're more proximal to the heart, you might need to have the patient rotate their head away from you and do some different neck and head positioning to get access to the subclavian artery or the brachiocephalic origin. Okay, so the anatomy that needs to be examined and the images that need to be collected in this upper extremity arterial study. You want to make sure that you are evaluating the subclavian artery, the axillary artery, the brachial artery, radial artery, and ulnar artery. As you work through and you assess these arteries, you're going to practice that typical standard protocol. You're going to be evaluating the artery in transverse, B mode, long, B mode, long color with spectral. So as you're doing your long with color and your long with spectral, you want to make sure that you're optimizing your Doppler practices. So make sure that you're using about a 45 to 60 degree Doppler angle, and make sure that your parallel lines of your sample, or that your sample line is parallel to the vessel wall, and make sure that you are assessing the peak systolic velocity of each region. When you have that peak systolic velocity, that's going to give you information about the possibility of upcoming stenosis or that you have passed a stenosis. In addition to that, if you identify a stenosis in your scanning, you're going to take your peak systolic velocity proximal to, at, and distal to the stenosis. And it's always good practice to walk your transducer through the stenosis until, so you're making sure that you're getting the maximal PSV. Okay. Now, when you do visualize thrombus or plaque, make sure that you're documenting that as well in B mode, demonstrating the makeup of the thrombosis or plaque, and then demonstrate it with color to show how it is affecting the blood flow through that area, whether it's occluding it, allowing a stream through, or just having a mass effect on it. Now, when we get to the subclavian, this is probably most frequently the most difficult area to assess. Having a nice transducer with a lower frequency and a small footprint like you see here in A is going to be a benefit to you. So using a curvilinear, or if you have it, a sector or vector, allows you to access that subclavian kind of through the jugular notch area. If you can't get it through the jugular notch and you have to go a little bit more laterally, again, you can angle down underneath that clavicle to assess that vessel, but the smaller footprint's really going to help you there. Other windows you might find success in insonating the subclavian artery are going to be through the supraclavicular area. So you see here in C, they're above the clavicle angling, or pardon me, in B, they're above the clavicle angling down, or even from the infraclavicular area, as we see in C here, where they're below the clavicle angling up. So all of these different areas are going to be possibilities for your assessment. It's also going, you'll probably have one you're most comfortable with, but you're probably going to have to adjust that according to patient habitus occasionally. Okay. So once you've evaluated that subclavian, you're really going to look for it. If you're on the right, you're going to need to assess it as it comes off of the subclavian. If you're on the left, you're going to want to try to assess it as it comes off of the aortic arch. So you're going to want to get deep down in there to assess this. Now, again, with this, you're going to have a little bit, because of your limited windows, you're going to have a little bit more difficulty assessing it in long and transverse. So you want to make sure to at least get it in long and make sure that you're utilizing your color to demonstrate the patency of the vessel there. So here's an example of, this would be on the right because we see this brachiocephalic vein. Here comes our common carotid off of that right brachiocephalic, and now here would be the origin of our subclavian artery. Here it is with color, and so we would actually be able to assess the brachiocephalic as well as the subclavian in this image here. Okay. The protocol. So as you are completing this exam, you want to make sure that you're following all the protocols. So we talked about how you're beginning with the beginning with the brachiocephalic or the subclavian. You're going to be following that subclavian laterally. As that subclavian passes through over the first rib, then we call it the axillary artery. So at this point, we're going to want to start assessing that axillary in transverse B mode, in long B mode, in long with color, and in long with color and spectral. And then you're going to want to take your peak systolic velocity there. You're going to want to assess it with color throughout the length of the vessel, looking for any areas of possible stenosis, and then document the stenosis if you come across it. Now we know as it crosses, as it exits the axillary region, that's when it turns into our brachial artery. The brachial artery is then going to course more superficial in the medial arm and between the biceps and triceps muscle. This is where you might have your patient move your arm from the stop sign position down to an adducted position with a supinated hand. At this point, you can assess that brachial artery in proximal, mid, and distal. Again, you're going to want to use transverse B mode, long B mode, long with color, and long with spectral, and take your peak systolic velocities with those in the proximal, mid, and distal regions. Once you have completed evaluation of the brachial artery through the distal region, you're going to see it bifurcate into the radial and ulnar arteries. And here you're going to want to assess the radial and ulnar arteries in proximal, mid, distal, in that same pattern where we're using the B mode transverse, B mode long, color spectral, and taking our peak systolic velocity readings at proximal, mid, and distal regions. Okay? And at that point, really most of your assessment is going to be complete. Now, if you saw any area of stenosis, occlusion, or aneurysmal enlargement throughout your scanning process, then you would, of course, want to document that specifically, and we'll talk about how you're going to go about that in each of those specific cases. Once you get all of your pressures in those particular areas, then you can assess, and if you see any significant drop in pressure from one area to the next, that would help you localize where the stenosis most likely exists.
As with all scanning, there can be impediments to an upper extremity vascular study. So things like wounds, dressings, IV catheters, or orthopedic fixation devices can make this much more challenging. But as you would with any other exam, you find ways to work around maybe angling under, angling over, putting a sterile covering on your probe. Things like that can all make a significant difference in being able to accomplish the exams despite the impediments. Now, when we get to the diagnosis of how we're going to classify any sort of stenosis from an upper extremity arterial study, we're really going to have to look at our Doppler waveforms for evaluation. So our normal Doppler waveform in our upper extremity artery is going to be triphasic. That means that we are going to have this, this sharp upstroke during systole. It will end here at the peak of systole, and then we should have a dramatic decrease until the blood flow will actually stop and then reverse, and then it will move forward and end diastole when the Windkessel effect kicks in. Now, this is what I would expect to see from an arm that's at rest. Now, we know that the arm is primarily made of muscles, and muscles have a low metabolic need when they're at rest. And so because of that low metabolic need, the arterioles feeding the muscles in the arm should constrict, causing a lot of resistance to the blood flow. So we would see this triphasic flow in that normal high resistance state. Now, if the patient goes and does 100 push-ups and comes back, this flow is going to change significantly, because you will see that the arterioles will then have to have dilated to meet the metabolic needs of the muscles, and then that dilatation of arterioles would allow for a decrease in resistance to the blood flow, and you would see something much more, we would see much more of a fast systolic upstroke peak, and then low resistance throughout early all the way to end diastole. Okay. Now, normal peak systolic velocities are going to vary from 80 to 120 centimeters in the subclavian, all the way down to 40 to 60 centimeters per second in the brachial, radial, and ulnar arteries. So our highest velocities are going to be as we're proximal close to the heart, and then those velocities are going to decrease as we go farther out into the extremity. So here's an example of a change in our spectral flow here, very different from the triphasic flow that we just looked at. So here's an example where we see that we're in the shoulder. This is the scapula. So this is likely in the axillary artery region. So here we see that there is a narrowing of this vessel, and when there's a narrowing of this vessel, it is going to change the waveforms both as we're coming into the vessel, to the narrowing, and as it exits the narrowing. So since our blood flow is transitioning out of the subclavian into the axillary, it's reaching this stenosis. What we're likely going to experience in this proximal to stenosis area, we are going to have an increased level of resistance, to the point where we might even lose some of this forward flow during diastole. So we might be looking at something that stays below the line until the next systole, and then we're below the line till the next systole. So this would show an increase in resistance as we're coming to that stenosis. Now, once we're in that stenosis, our waveform should normalize a little bit, but what we're going to see is a significant increase in velocity. So you'll see your velocities go up because we know that law of continuity tells us that in order to maintain the volume of blood flow despite a stenosis, we have to move that blood more quickly. And so as we're going through that stenosis, we're going to see those peak systolic velocities increase significantly. Now, if we're looking just distal to the stenosis, maybe right in here, this is the area where that blood flow is going to be coming out of a stenotic area and it's going to become turbulent. So if this was my stenotic area, blood flow is coming through and all of a sudden it has room to move around again. So it's going to start with some turbulence. And so it might look something like some forward motion, but also some backwards motion as well. Some forward, some backward, so on and so forth. So you will have a very irregular pattern as we get into this turbulent area post-stenosis. Now, as we go farther downstream after post-stenosis, what we usually see is that there's a lack of pressure of the blood moving through. We've lost some of the volume of our blood here at the stenosis because despite the best efforts, it's not able to get the same volume of blood through that stenotic area that it is through the vessel itself. Because of that, there's less pressure pushing blood flow forward. And so what we will also often see posterior to a stenosis like this is a much lower resistance waveform. Now, the waveform that you're seeing here on the left, this is another example of what we could see pre-stenosis, where that pressure is pushing it forward and then it's just coming to a stop and not moving at all until the next systolic beat. All right, so if we really want to evaluate our abnormal findings, just like we did with the lower extremity, we're going to be counting on that those peak systolic velocities to demonstrate or tell us exactly what percentage of diameter reduction we're looking at. And so you can see on the chart here that it's giving us some conditions and some characteristics. So if I have a very normal arterial system, I should see that uniform waveform, which is biphasic if it's low resistance and triphasic if it's high resistance. And we know low and high resistance can be normal in any vessel that's feeding a muscle. And that's going to be simply dependent on the metabolic need or the activity level of that muscle at that particular time. Now, once we get to a 50% diameter reduction, it's typically needed to be 50% or more to be considered hemodynamically significant. Once we get to that particular diameter reduction, we'll start seeing focal velocity increases at the stenosis itself. We can see some spectral broadening and triphasic or biphasic flow. Again, our flow pattern might look pretty similar within the stenosis itself. We don't necessarily see those pattern changes until we get into the turbulent and post-stenotic area. Now, once we get up to a greater than 50% diameter reduction, that's when we start to see significant focal velocity increases. We lose that triphasic or biphasic flow, and we get a lot of post-stenotic turbulent flow. And if we're reaching the point where the vessel is occluded, we would see no flow detected at all through the stenosis. So abnormal findings include an elevated peak systolic velocity. How high that velocity is going to be an indicator of exactly how bad the stenosis is. We're going to see post-stenotic turbulence. We're going to see a dampened distal waveform with the loss of end diastolic flow reversal. Now, this is saying that we get forward motion during systole, and that motion tapers off during diastole, but we are now missing that normal reversal component that we're used to. Now, this is because that reversal comes from resistance ahead. Now, if this is post-stenotic, we have already decreased enough of the blood volume that we're not able to meet metabolic needs, and so we're not reaching the point of resistance to cause that early diastolic reversal. Okay, general guidelines suggest that a velocity ratio greater than 2 is consistent with greater than 50% stenosis, and that waveform changes and brachial blood pressures, such as those done in the physiologic studies, can help determine how significant that stenosis is. So here are some more examples. Here would be, you can see this is probably the let's see, the aorta, the brachiocephalic, the left carotid, and then this would be the left subclavian. Very significant stenosis, although it's not occlusive. You can see that there is still contrast moving through this area, just to a much lesser degree. So if we were coming into this stenosis, what we'd likely see is something that looks similar to this waveform here on the left. We would see good systolic upstroke, and then no resistance or continuous motion during end diastole. And that's because that blood is like pounding into a wall. It's hitting that wall, stopping, hitting that wall, stopping with every beat. Now, as it goes through this particular stenosis, you would expect it to retain or return to some of that more normal waveform, but you would also expect to see a much higher than expected peak systolic velocity here. Now, distal to that waveform in this region, you might see something that looks like this. You can see that that volume of blood flow in this region is now decreased, and so there's really no resistance against the form because the volume is so low, so blood just flows forward in a very low resistance pattern. So some of the challenges with Doppler in the upper extremity is getting appropriate angles of insonation because of, especially at the proximal arterials, they're close to the heart, they're under some of the ribs, they're under the clavicles, and it can be very difficult to access those and get appropriate angles because you just have such a lack of mobility in that area. So angles of insonation can be difficult, especially at that brachiocephalic because of its location posterior and inferior to the clavicle especially. In this case, the elevated left proximal subclavian peak systolic velocity of 247 centimeters per second may not indicate a hemodynamically significant lesion. It could be due to the abnormal access that we have to the vessel itself. So really when we're looking at our brachiocephalic, our subclavian, we're really evaluating more of the triphasic appearance of that vessel than of the peak systolic velocity. When we look at documentations of abnormalities, it's really important that, first of all, if we find a stenosis, we're documenting it proximal with the highest peak systolic velocity and distal at the turbulent area, and then distal once the flow has resumed. We want to make sure that we're documenting it in all of those areas. If we see something like we see in this image here where it appears that the vessel is occluded, we need to be absolutely certain that we're demonstrating any flow if there is any. We can do this by optimizing our technique. So rather than using low gain color Doppler, you're going to pump up your color Doppler gain as high as you can, decrease the scale. If you can't see it with your color Doppler, you might consider going to power Doppler. You're going to pull out all the stops to try and get any flow that may still exist within a stenosis, because that would indicate that the patient may still be operable. Once that flow is completely occluded, they are no longer operable. So your ability in this area to find that flow, if it does exist, is going to be essential. All right, now one of the abnormalities besides stenosis or occlusion that you may find in the arterial system is an aneurysm. So aneurysm is a permanent localized dilatation where the vessel itself has a 50% increase over the diameter of the normal artery. So we would see maybe if something measures 1 centimeter in a particular region, and 2 inches down the line, it measures 1.5 or more, that would be considered an aneurysm. When we're looking at these aneurysms, we need to make sure that we're doing appropriate measurements, and we need to be aware that aneurysms may often occur in subclavian arteries in association with thoracic outlet syndrome, excuse me. These can be difficult to visualize due to subtle changes and the location near the bony landmarks, which affects our ability to access these. If we do find them, it's really important to document and measure them and determine if there's any intramural thrombus. So we would want to make sure that we are, when we're documenting an aneurysm, we are going to be measuring proximal to diameter, at the widest area diameter, distal to diameter, and then the length of the aneurysm itself. We also want to make sure to add color flow here and see, we'll expect to see a turbulent region within the aneurysm. If we do not see that turbulence filling the whole aneurysm, we will be concerned then that there could be a clot reducing the lumen, making it almost look normal. Okay, there's another abnormality called hypothenar-Hammer syndrome. This is, interestingly enough, a bad habit of some people, where you can use your hand as a hammer. And when you're doing that, when you're using your hand or your palm region as a hammer, it can actually cause degeneration of the ulnar artery as it passes deep to the hook of hamate in your carpal bones. And so because of that, it can affect the blood flow to that region. So that's another syndrome you may encounter, especially in those digital arteries. Raynaud's syndrome, sometimes known as Raynaud's phenomenon, is an unusual event where a person may have intermittent distal ischemia from cold exposure or emotional stimuli. So this patient might just have the syndrome where when they're out in the cold for a little bit of time, if they are overstimulated, their arterioles constrict significantly and cut off the blood flow to their fingers or toes. Primary Raynaud's syndrome is abnormal digital artery vasospasm resulting in pain and color changes. It can also result in numbness and from the vasospasm. So it can be those arterioles constrict, you're no longer getting flow to your fingers, so a pale to blue color of the hands would be very common. Anatomically, the digital arteries appear normal. There's no stenosis there. It's just their physiologic reaction with that arterial constriction that's going to be causing the issue. Because usually once they get warmed up or that emotional stimuli is reduced, those arterioles will go ahead and relax, blood flow will be restored, and typically no tissue damage is accumulates. So then there's another type that's called secondary Raynaud's syndrome, and this is usually an autoimmune disorder underlying the disease, which can be common with patients that have mixed connective tissue disease, lupus erythematosus, rheumatoid arthritis, drug-induced vasospasms, cancers. Now, these patients that have secondary Raynaud's syndrome are more likely to develop occlusive lesions and have tissue necrosis. Thoracic outlet syndrome we briefly discussed, but this is the impingement of the neurovascular bundle at the thoracic outlet. This is where the subclavian artery passes between the clavicle and the first rib, and if we have hypertrophy of those pectoral muscles or something else in that region, then it can cause compression of those, not just the vessel, but of the nerves going through that region as well. So duplex ultrasound can be helpful in identifying this. Evidence is not supported that it is always going to discover a thoracic outlet syndrome. Major arterial thoracic outlet syndrome occurs primarily in younger patients, typically young men that are in really good shape, and then they have very prominent muscles in their arms and upper chest. Trauma to this area. Trauma patients can undergo arteriography or direct surgical exploration when vascular involvement is suspected, so that we may not be the test of choice in this particular situation. Numerous studies have shown that arterial duplex can be a valid alternative, but depending on the impediments and different things in context of the trauma, it may determine whether ultrasound could be used or not. The ultrasound examination would be the same as those used for upper extremity evaluations, but rather than really looking for a stenosis, you're looking for disruption of that arterial system. Occlusive disease, we already talked about this, is most common in the subclavian. It's often an extension of atherosclerotic involvement of the aortic arch. So it's probably going to start in the arch and then extend into the subclavian. It rarely produces symptoms in the upper extremity, but can result in subclavian steal syndrome if it's a very significant case. When we have subclavian steal syndrome, if my subclavian artery is blocked off, my subclavian goes and feeds my arm, whereas my carotid goes up and my vertebral is on the other side of my subclavian obstruction. What will happen is it will create the subclavian steal where my carotid goes up, it feeds the brain, it communicates with the other side through the circle of Willis. Usually my vertebral comes up that subclavian, off that subclavian, comes up in my basilar portion and feeds the back of the brain. But in this case, because that vertebral artery isn't getting any blood flow due to the subclavian occlusion, what will happen is the blood flow from the carotid will reverse course and go retrograde flow in that vertebral artery and end up going down to feed the arm. So that's a subclavian steal. It doesn't happen overnight. It progressively gets implemented over time, but it's usually because of that subclavian occlusion. The next disease we'll talk about is Takayasu arteritis, and this is an autoimmune disorder that affects the arteries and aortic arch and the visceral abdominal aorta. And it's most common in younger women in their 20s and 30s, and it results in long segment of occlusion or stenosis of affected arteries, which can be associated with fever, malaise, arthralgias, and myalgias. Lab studies can be evaluated looking for a sedimentation rate and C-reactive protein. These patients can be treated with immunosuppressive medication or steroid treatment, and then the duplex scans that we can do can monitor response to that treatment. If patients are effectively treated, but after a significant amount of damage, they may need to have vascular reconstructive surgery. Giant cell arteries affects mostly women over 40, and it can involve the ophthalmic, subclavian, axillary, and superficial temporal arteries, and they are going to show evidence of flow restriction and thickened hypoechoic arterial walls. That's where the giant cell's coming from. These can be treated with anti-inflammatory and immunosuppressant medications to reduce those sizes of the cells. Thromboangiitis obliterans or Buerger's disease. This involves the small vessels of the hands and feet, often seen in smokers under 50, and it uses duplex ultrasound to rule out any proximal occlusive lesions, but it's not often able to actually identify the cause of the actual disease. Most patients with this will improve if they're able to stop smoking. So in summary, extensive knowledge of vascular anatomy and Doppler techniques is essential in accurate assessment of upper extremity arteries. The pathology in the upper extremity is going to be less common than that of the arterial system of the lower extremity. Maintaining a consistent protocol is essential to consistent diagnosis and evaluation, and the addition of physiologic studies can contribute to a diagnosis. In fact, sometimes a site protocol may require you to go through a physiologic study primarily. If the patient passes those studies with no abnormalities, you may not even go on to the actual arterial duplex exam. So that's something to consider adding into your protocol if it's of interest to you. Well, I thank you so much for joining us in yet another lecture, and I hope you have a wonderful day.